I am Dr. Faisal Hanif. I'm working as head of Hepatobiliary and Liver Transplant Center at Bahria International Hospital, Lahore. I'm giving a talk on the principles of living donor liver transplantation. This talk is primarily for undergraduate students and postgraduate trainees. So the most of the contents are very basic contents and is not very specialized for liver transplant surgeons. My purpose was that undergraduates and postgraduates should understand basic principles of living donor liver transplant. I will go through a bit of background of living donor liver transplantation. I will talk about how living donor liver transplantation is different from cadaveric liver transplantation. I will also introduce essentials or the requirements of a successful living donor liver transplant program. And finally, I will share some success stories of my own center. So Tom Storrs made the history by performing first ever successful liver transplantation in 1967 at the University of Colorado Health Science Center. Another person I would really like to introduce is Professor Roy Cohn, who has the honor of performing first liver transplantation in Europe in 1968, the world's first liver, heart, and lung transplant in one patient as a combined procedure in 1987, the first intestinal transplant in the UK in 1992, and the first successful cluster or a combined transplant of stomach, intestine, pancreas, liver, and kidney in 1994. As most of you know, the indications of liver transplantation are based on all those conditions which can cause liver cirrhosis, such as primary biliary cirrhosis, secondary biliary cirrhosis, non alcoholic fatty liver disease, and obviously hepatitis B and C. And then there are some metabolic or congenital problems which can cause liver failure. In Pakistan, the commonest cause is hepatitis C and hepatitis B related chronic liver disease. As you know that chronic liver disease is classified into A, B, and C, and we should know that 1 year survival of class C liver failure patient is around 45%, class B is 80%, and class A patients are expected to survive at least 1 year after diagnosis. A typical liver patient has severe portal hypertension, coagulopathy, they are severely thrombocytopenic, malnourished, and many of them have hepatocellular carcinoma. We use MELD score, which help us in deciding when to put a patient on waiting list for liver transplant. Higher the MELD score, more the urgency is to offer a liver transplant. In general, if MELD score start going above 15, those patients should have liver transplant. This is a busy slide, but in general, if patients have chronic liver disease with portal hypertension, and if they develop liver cancer, In fit patients, the option is to offer them liver transplantation. If they do not have portal hypertension, they can even undergo liver resection. Otherwise, those patients who do not fulfill these criteria, they can be offered procedures such as ablation, chemoembolization, or systemic therapy. We also use Milan criteria, which was published in 1996. And according to Milan criteria, if a patient has hepatocellular carcinoma with a size of less than 5 centimeter, or if there are up to three tumors, each less than 3 centimeter with no vascular invasion, then those patients benefit from liver transplantation. In other words, patients who do not fit into this criteria, their chances of recurrence and their survival is limited as compared to this group. So, what is the difference between cadaveric donor versus living donor liver transplant? In Western population, where cadaveric donation is more common as compared to our country, where it is almost non-existent, majority of the liver transplants are carried out with cadaveric donors. Those are the people who have brainstem death in ICU, and their families want their organs to be donated, as that was the wish of the patient before their death. In cadaveric donors, you don't have to worry about the donor because that donor already has brain death. The graft is full size graft, the blood vessels are large, and usually no extra vascular reconstruction than the usual one are required. And that is why the outcomes are better with lesser incidence of vascular and biliary complications and complications such as small for size syndrome. So this is a standard full size graft. An implantation require IVC to IVC reconstruction and similarly portal vein, biliary, and hepatic artery reconstructions after taking out the recipient diseased liver. In living donor transplant, the problem is that donor has their own risks. The graft is usually smaller. The blood vessels are smaller because they belong to only one side of the liver, and therefore there are more risk of small for size syndrome and vascular and biliary complications. So this is a slide for everyone. So generally we like to have donor with age group between 18 to 40. BMI should be less than 30. They should be ABO compatible, should not have any liver disease. They should be fit. And we also assess them for suitable anatomy with the help of CT and MRCP. We also use graft ratio versus recipient weight ratio, and that should be one or more than one. And we also want to have that the remaining liver in the donor is more than 30% of the total liver. Cadaveric transplantation requires a lot of infrastructure and logistic support which doesn't exist in our country, and that is why we have to rely on living donor liver transplantation, which is technically much more complex and challenging. So it is crucial for success of a living donor liver transplant program that you have suitable facility, trained faculty, you have all the necessary equipment and support available. Only then you can have excellent outcomes. The operating space is usually larger than usual because you have a lot of equipment to go in. It is recommended to have independent operating theater where no other surgeries are performed. Operating microscope can be very helpful if the surgeon is trained to use it for hepatic arterial reconstruction. And the usual other gadgets are rapid cell infuser, Cavitron ultrasonic aspirator, organ beam plasma coagulator, intraoperative Doppler ultrasound inside theater facility, and intraoperative fluoroscopic facility. Similarly, we had the anesthesia team use TAC machine for thromboelastography, and that helped them in deciding that what sort of blood products patients are requiring during the surgery. So this is a CT volumetry scan which show us, for example, in this patient, their total liver volume is 1267, the right lobe is 791, the left lobe is 476, and that helps us in deciding if that particular patient or the donor is suitable for their recipient. This is 3D reconstruction of hepatic arterial anatomy. This is accessory right hepatic artery, left hepatic artery, and celiac axis. This is 3D reconstruction of portal vein, common portal vein, right and left portal vein. And same 3D reconstruction of hepatic vein, right hepatic vein, middle hepatic vein, and left hepatic vein. This is a reconstruction image from an MRCP which shows common hepatic duct, right hepatic duct, and left hepatic duct. So this is a right lobe donor, and all the transaction is completed. This is right lobe, this is left lobe, and you can see here right hepatic artery, common bile duct, and the cystic artery here. And this lobe is now ready to come out for donation. So this is a donor graph which shows right hepatic vein, right portal vein, right hepatic duct, right hepatic artery, and this is reconstructed segment 8 drainage with a synthetic graft. This is the same graft after implantation showing reconstruction of the segment 8 vein here into the IVC. So this is another right lobe graft in which we have reconstructed the middle hepatic vein by taking part of it, and then remaining has been, the continuity is restored with the help of a Dacron graft. So this is microvascular anastomosis of right hepatic artery with the microscope. And this is image of methylene blue testing after biliary reconstruction. This is intraoperative cholangiogram after biliary reconstruction. And this patient had X-type portal vein, so we ended up having two portal veins with the right lobe graft, and this shows how we reconstructed both portal vein with posterior venoplasty and a great saphenous vein reinforcement. Chiral patch was sutured to it as well, and that facilitating implantation. So living donor liver transplantation is essentially a gift of life to your loved ones. So these are some examples. So this is a 50-year-old recipient who had chronic liver disease due to hepatitis C and received a successful liver graft from his brother who was 42-year-old. This is a sixth post-operative liver transplant donor who was father to his son. This is seventh post-operative day after liver transplant from mother to the son. This is 3 months post-liver transplant from son to father for liver cancer. This is my team. Thank you very much.